Okay, so welcome to our special continuing professional development webinar for social workers and social care professionals. My name's Gradle Gardner-Martin and I am the owner of Elevate Training and Development. I'm really pleased today to be welcoming Frank Barnhill MD all the way from the States by the amazing miraculous powers of and technology of modern technology, and we have ironed out the wrinkles so that we can do this webinar today. Frank is an expert in the field of ADHD and he will be presenting today's webinar. So welcome to all the people who are watching this live and people who will be watching the replay. One of the things to say around this continuing professional development training is that, we know as social care workers that ADHD continues to be one of the most diagnosed childhood conditions, and Frank's really going to go into that in some detail with us about what's happening in the States and what's also probably mirroring issues to do with children and young people in their families here in the UK. And Frank's going to share with us some of his research, his outcomes, help us to see some practical things that we can do as workers working with children and families with these conditions or what are thought to be these conditions. And Frank will take any questions at the end of the presentation, so please type them into the chat box and I'll collate them for him and he'll answer them if he hasn't answered them already in the presentation right at the end. So welcome, Frank.
Great to be with you, Gradle.
It's lovely to have you. I'm going to hand over the presenting to you so we can see your screen right now.
Okay, very
Excellent.
good.
I'm going to mute myself now, Frank, all right?
As we were discussing, Gradle, ADHD is currently the #1 psychiatric diagnosis rendered in children worldwide. It's becoming increasingly common in incidents regardless of what country you're in. And I think today we need to consider two important things to take away from this presentation. The first being that what looks like ADHD isn't always ADHD. Just because a child appears to have ADHD does not mean that he or she truly has ADHD. And the second point is that failure to properly diagnose and treat ADHD can be just as devastating as misdiagnosing a child as ADHD. And we'll go into both of those as the presentation continues. First of all, I'd like to tell you a little bit about myself. Almost always when I do interviews, someone asks the question, how did you get to the point, how did you become infatuated with the goal of presenting and educating about the misdiagnosis of ADHD? I've been in family medicine for 32 years. I'm a board-certified family physician. And about 16, 17 years ago, I noticed I was seeing increasing numbers of children in my practice, new children, kids that their moms and dad brought in and asked me to evaluate their behavior problem, whether it was ADHD or not. And these kids sometimes were taking as many as 4 or 5 medications and going through behavioral therapy, yet their behavior was not improving. So I started researching all of the things that could mimic ADHD and confuse the diagnosis. And at the time I discovered about 20 things, mostly medical problems like thyroid disease, diabetes, seizures, post-traumatic brain syndrome. That's a condition that occurs after someone suffers a concussion. And as I continued my research over the ensuing 10 years, I finally decided I needed to educate the public. I needed to educate professionals, moms, dads, teachers, social workers, other doctors, even lawyers and policemen. because ADHD really has a dramatic impact on the family as a whole. It does not just impact the child, the teen, or the adult that is labeled ADHD. It impacts everyone that is in their life, everyone around them. And we'll discuss that a little more. So as a consequence, I wrote a book, Mistaken for ADHD, in hopes that it could be used as a guide to ensure that children were properly evaluated and diagnosed for their ADHD, hopefully preventing the misdiagnosis of ADHD while simultaneously ensuring that if a child really were ADHD, that he or she would be treated appropriately. With that in mind, we'll proceed. Every social worker that I have dealt with, several are very good friends, tells me these are the things that they see as responsibilities in their life and their work. They see a responsibility to their clients, the kids, the teens, the adults whose lives they touch, because in troubled times, of course, their responsibility is to guide and help nourish those families and help solve problems. They also have a responsibility to the social system that employs them and allows them to work as a professional. They have a responsibility to their fellow workers, because everything that we do as professionals affects our co-workers, our co-professionals. Their very existence sometimes depends upon how we handle a situation. And of course, each of us is lastly responsible to ourselves. At the end of the day, and at the end of a hopefully long and fruitful life, we have to answer. And we answer to ourselves. We have to be satisfied with what we have done in life to help others. Here's the big problem with ADHD. The statistics are terrible. Currently, as low as 9% and as high as 15% of the child population around the world is felt to be ADHD, or they have at least been diagnosed as ADHD. In the United States, that translates to approximately 10 million children between the age of 5 years and 17 years. Coincidentally, between 5 and 12% of adults are felt to be ADHD. Now, during the course of writing my book, I discovered research that showed that as many as 25 to 40% of all children who had been diagnosed as ADHD and labeled as ADHD truly had been misdiagnosed. In other words, they had another condition that was responsible for their behavior, but that condition made them look like, act like, and feel like they were ADHD. Unfortunately, as many as 15% of adults who have been labeled as ADHD are also misdiagnosed with the disorder. Labeling anyone, particularly a child, as ADHD can profoundly affect their future. It's been shown in research studies that up to 75% of children and adults who have been labeled as ADHD suffer discrimination and bias. This can occur in the classroom, socially, or even at work, and we'll discuss that a little more later. Once you're labeled ADHD, everyone assumes that you're ADHD. Once someone makes just a comment that that child or that teenager or that adult is ADHD, that label sticks like glue. It's very difficult to remove that label. And the label causes these children and adults to be treated differently. Who treats them differently? Well, the list is long. It can be siblings, parents, other relatives, the neighbors, teachers, classmates, law enforcement officials, and judges. Give you a quick example of how that can occur. Several years ago, I got a telephone call from a lawyer who wanted me to write a letter about a 17-year-old who was ADHD because he was going to try to use the 17-year-old's ADHD diagnosis as an excuse for the teenager driving recklessly so that he could help get the young man off. In other words, avoid losing his driver's license. To me, that's terrible, and of course I declined to do that because ADHD does not really impair judgment. What it impairs is concentration, the ability to focus, and the ability to make decisions. Children and teens who have ADHD truly know the difference between right and wrong, and they have to be held to the same standard. They may need accommodations in the classroom and at work, but they do know the difference between speeding and not speeding, so I declined to do so. The military has started to ease up a little on its bias against teenagers and young adults who have a diagnosis of ADHD. The bias is still there. As an example, about 3 years ago, I had a young lady who wanted to enter the Air Force Academy, and once they discovered that she had been treated for ADHD in the previous 5 years, they declined her admission. She was a straight-A student, and she deserved the opportunity but did not get the opportunity because of the diagnosis. Employers, likewise, are very weary of teens and adults who have a diagnosis of ADHD. They are afraid that they won't complete projects assigned to them. They're also afraid that they will make, quote, stupid mistakes on the job and possibly get hurt. So there's a lot of bias and discrimination there. Social systems also show bias and discrimination against those who have ADHD. For example, there's a study here in the United States that shows that at the poverty level, more children are diagnosed as ADHD, but the way they are handled, the method in which their treatment is handled, is not up to par. That has a lot to do with the bias that goes along with, quote, poor people are more likely to have behavior problems, and that doesn't necessarily mean that those children are ADHD. So a lot of doctors just assume that the child's socioeconomic status and their family's ability to provide for them is what's causing the behavior problem, and they want to blame it on poor discipline. And that's not always the case. How do we prevent mislabeling a child or a teen or an adult as ADHD so that we don't end up with bias and discrimination? Well, as social workers, you have three very important tools. You use information obtained by direct observation, what's written, and what is communicated to you verbally. I like to point out to my social worker friends that they have two very important tools, and those are common sense, intuition, and sometimes just using a hunch. Most of you as social workers are really good at your hunches. After you've been in your profession for a couple of years, you can see through the veil. You can see through the lies and the innuendos. And I point out that just like me, a lot of social workers have a background similar to Sherlock Holmes. We have a high index of suspicion. Our curiosity is overwhelming, and we have this burning desire to find out everything we can about what we're dealing with. Now, here are the common mistakes that are made when dealing with ADHD children and teens. Now, social workers are not the only professionals that have a problem with these areas. Medical doctors have problems with this too, and that's part of my education efforts, is to educate. We have to look first, look before we leap. As a society, we want the quick fix. We're in too big of a hurry to put a diagnosis on everything and give that thing a pill, hopefully to cure it. So I ask everyone to slow down and take a second look. Now, here are the mistakes. Too often, when we see a child who's been diagnosed as ADHD, we assume that the diagnosis was properly made, that it's a correct diagnosis. We assume that whoever made the diagnosis did it the right way. Unfortunately, 95% of the time, that's not true. Only 5% of children are adequately evaluated for their ADHD before they are labeled as ADHD. The other thing is we often fail to get an adequate history from more than the parents. This is very important, especially as a social worker dealing with distressed families. I know just a few weeks ago I had a lady showed up in my office going through a nasty divorce, and she tried her best to convince me to go to court with her and swear that her son's behavior problem and his ADHD was a direct result of her husband. Her husband's attitude, the way he treated the children, and it just was not so. That was not a correct assumption. She was looking for a way, of course, to get the divorce, and to do so with a minimum of, her lack of conscience. In fact, she is the one that broke up the marriage, and she was just trying to ease her own conscience. So it's very important to get a history of the child's behavior from the parents, hopefully from the grandparents, from teachers, next door neighbors, and of course the doctor. Often we forget that the parents do have a selfish ulterior motive for providing too much information, or in some cases deleting or failing to mention certain information. A lot of professionals overlook the best source of information about the diagnosis, and of course that's speaking with the nurse or the doctor who takes care of the child, the teen or the adult. I encourage all of my social worker friends to go to a doctor's visit with the child and with the parents if possible, so that they can observe the child's behavior in the presence of all three. There have been times that I saw a child suspected of ADHD who truly was not ADHD, and his or her behavior was directly a result of one or both of the parents being in the room at the same time, or a sibling. For example, this mom brought in a 9-year-old boy several years ago, and her daughter was also with them. And the entire time during the interview, she kept emphasizing to me how he was disruptive, how he was mouthy, how he had bad attitude, how he wouldn't study, how he didn't get along with anyone in the family. But I'm looking at this 9-year-old, and he's sitting there He's sitting there very quietly. He had been reading a book, and he did not interrupt. He didn't have a bad attitude by a long shot. I asked a bunch of questions, and he answered the questions, and then suddenly his behavior changed. He became upset, disruptive, oppositional. And what set his behavior off was his sister. For no reason, his sister just started picking on him. She started punching him in the arm, calling him stupid. She kept saying, he's the one with the behavior problem, he's the one with the behavior problem. And of course, the mother chimed in and agreed. And it was obvious, and I pointed out how obvious it was, that the child was not ADHD. By the time I finished all of his evaluation with his physical exam, his blood work, and his psychological testing, he was a little anxious and a little depressed. But he was actually being bullied by his own sister, and that's what was producing his behavior. So observing a child's interaction with the family is very important, and if it can be done at the doctor's office, that's even better. Now, here are the questions as a social worker that I would ask the nurse or the doctor about a child who had been diagnosed as ADHD. I would want to know who made the diagnosis, the original diagnosis. Unfortunately, in today's world, ADHD children probably end up seeing 4 or 5 doctors during the course of their treatment. So each doctor may very likely have assumed that the doctor who saw the child last or first or whatever made a proper diagnosis. That may not be true. We want to know psychological tests. We want to know what type of blood tests were done. Who prescribed the medications the child is taking? Are they really working? And when was the last time a doctor evaluated this child? Those are very important questions. Likewise, who was present with the child during that office visit? Was the mom there, the dad, the grandparents, the next door neighbor? I've even had a great aunt bring a child in for ADHD follow-up, and the entire time I asked questions, her response was, I don't know, I really don't know, I'm not his mom or dad. And see, that didn't do a lot of good. That office visit wasn't completely wasted, but almost. So we want to know how the child and the attendant during that office visit interacted. Does the doctor know of problems in the family that could be responsible for causing the child's behavior? Maybe the doctor knows something that we don't know. Maybe he knows that mom and dad have a drinking problem that's been hidden, or a problem with drugs, or that they're having infidelity problems. Was the child having any side effects of therapy when he or she was on therapy, and when and what medications were changed? Also, what type of cognitive behavioral therapy has been used? Has it been group therapy, coaching? I happen to like coaching. Coaching is a more one-on-one. Sometimes a coach will work with 2 or 3 children at a time, but it's not like group therapy. It's more of a buddy parenting type system. And how has the child done over the past 3 to 6 months? What has changed? Now, here are the mistakes that doctors make when they're evaluating ADHD. First of all, they really don't get a good history from more than one person about the child's behavior, and about the child's behavior in more than one environment. As each of you well know, ADHD is diagnosed based on hyperactivity, impulsivity, and poor attention span, inattentiveness. The facets of diagnosis must include the fact that the child's behavior causes a disability in more than one setting. In other words, if the child just has a problem at school, likely it's not ADHD. If the child just has a problem at church, it's probably not ADHD. If the child just has a problem at home, likewise, there's something else going on causing the problem. In order to make the proper diagnosis of ADHD, it has to occur in two different settings, and it has to cause the child some type of disability, whether it's a problem learning, a problem with social skills, or a problem controlling his or her behavior. Secondly, most doctors don't even speak to the child. They don't talk to the child about what's going on in their head. I've seen 10-year-olds on 3 ADHD medications when they first came to my office that had been treated by as many as 5 doctors, and not a single doctor had sat down to converse with the child. I find often this is more true in children who are around 5, 6, or 7, because the doctors feel that they have to get all of the history and all of the interview from the parents. Another common mistake: we assume that if a teacher says that the child is ADHD, then they are ADHD, and that's all there is to it. Unfortunately, in the United States, that's a common misconception with parents too. Once a teacher calls a parent and says, your son probably has ADHD, that's usually it. It's very difficult to reverse that. It's hard to prove to that parent that the child's not ADHD unless the child ends up having a major medical problem. Another problem that I see, another mistake doctors make, is they don't try lifestyle changes before placing these children on drugs. As we discussed earlier, it's just too easy to start a drug. It's so easy to write a prescription and say, here, give little Johnny this pill and his behavior will get better. What could be easier than that? It takes just a few minutes. And unfortunately, that's not the way to treat ADHD. Most doctors don't give medications time to reach full effect because parents come in 3 or 4 weeks later and say it's not working, and they immediately want to change the drug or go up on the dose. I find that most doctors likewise do not evaluate children often enough after they start medications, and they fail to do one of the most important things. They don't goal set with the parents or the teachers. They don't set expectations. They don't define what is and what is not successful treatment for that child. And as you well know, every child responds differently to therapy, whether it's a drug or whether it's behavioral therapy. Their response is totally different. And you have to do that with each and every child in order to reach your goals. So how can you, as a social worker, as a professional, tell when a child's ADHD therapy isn't working? Or what should make you suspicious that the child really does not have ADHD? Well, these children will have continued failing grades. They'll make poor grades. Their behavior will get worse despite the medications. Or they will suffer terrible social skills. They won't make friends. Teens won't date. They won't be able to get a job. There are a lot of indicators. Now, the behavior might not be ADHD. As we pointed out earlier, 25 to 40% of all children who have been labeled as ADHD probably are not ADHD. Instead, something else is causing their behavior. It might be social, it might be medical, it might be psychological, it may be environmental. Now, ADHD behavior can result from significant side effects of drugs. Legal problems can result in a child or teen acting as if they have ADHD. And when a parent complains frequently about what's going on in the child's life, that's an indication that something else is going on. If the child's being treated appropriately for ADHD or his behavior problem, and you still get a lot of complaints from brothers, sisters, mom, dad, the teachers, Sunday school teachers, there is something else going on. It may not be ADHD. There are several common psychological and social problems that can cause a child or teen to act like they have ADHD. It can produce the behavior consistent with ADHD. Currently, there are over 70 medical, social, psychological, environmental problems that can cause a child to be mistaken for ADHD. And many of you already know this list, but I'll cover it for you and we'll discuss it. Neglect. Child neglect. I saw a child one time that repetitively irritated his mom and dad just to get attention because he was a neglected child. In fact, that child was abused. Both adult and child abuse can mimic ADHD. Bullying. Give you an example of bullying. I removed a 12-year-old from his class about 3.5 months ago because the child had every symptom of ADHD, but I could not find a reason for the ADHD. And on the third office visit, he finally broke down and told me that another child in his class was picking on him constantly, calling him fat, calling him stupid. So we moved him to another classroom that was clearly away from the location of the first. And within 30 days, his behavior improved and so did his grades. Classroom bullying is not the only type of bullying. As we discussed earlier, siblings can bully, and people on the job can be bullied. Adults can be bullied. One of the other social problems that can cause ADHD behavior is divorce. And of course, if the parents are using drugs or alcohol, a recent death in the family can do that. I had a child several years ago whose grandfather passed away, and instead of acting depressed, he developed inattentiveness and impulsivity. And his teachers thought he had ADHD. But truly what was wrong was he was depressed about his grandfather's death. And once his depression was treated, his ADHD symptoms went away. Generalized anxiety disorder can cause ADHD symptoms. Bipolar disorder, psychosis, those are what we call the little mini hallucinations. Children who have psychosis rarely act like adults with psychosis. Their symptoms are much more sort of covert. They're very mild. You have to be very careful with these children because it's easy to miss them. And we mentioned post-concussive disorder earlier. That's direct brain trauma or indirect brain trauma causing a concussion that causes a change in behavior. Now, currently, these are the 5 most common medical problems confused with ADHD. Number 1 in my practice, and of course it would be in my practice because I receive the bulk of the referrals from teachers, parents, and other doctors when a child is not getting better. In other words, when their ADHD is not responding to therapy or the diagnosis is very confusing, they end up in my office. If they're doing well on their ADHD medications, of course they stay with their pediatrician or their family doctor or psychiatrist, whoever is treating. But when problems arise, most of the time I end up seeing the children. The 5 most common medical problems that cause ADHD misdiagnosis that I see are visual sensory processing disorders. These are usually convergence disorders. And basically, if a child cannot read what he or she sees, then he or she can't learn, and it disrupts their behavior. Convergence problems are very common. In the last 12 weeks, I've diagnosed 9 children with convergence problems. I had to refer them, of course, to specialists to confirm the diagnosis and start the treatment. My most successful case, the most successful young lady I have ever treated, is now 13. We started her therapy when she was 9. She had been on 6 medications and wasn't getting better. And I discovered she had visual sensory processing disorder. And she went through training. Her handwriting improved. A lot of these children write upside down. They can't follow a straight line. So this is a very important facet of diagnosing and taking care of ADHD children. Seeing more and more Asperger's, autism spectrum disorder, showing up both in kids, teens, and adults. It confuses the diagnosis. Sometimes the two are coexistent. It is a comorbidity. ADHD can exist with Asperger's. Thyroid dysfunction, particularly low thyroid hormone, prediabetes, and dietary imbalances. I got a referral from one of the medical universities just a few weeks ago about a child who they just could not figure out why his ADHD was so resistant to treatment. He ended up having celiac sprue. We have him on a gluten-free diet at this point. He also was pre-diabetic, and his mom sent me an email yesterday and said that his behavior was approximately 75% improved after the first month. That's remarkable that diet can do that, but vitamin deficiencies can do the same thing. I'd like to point out that studies clearly show that overall the best ADHD therapy combines at least one drug with cognitive behavioral therapy. Now, I find that lifestyle changes will improve ADHD behavior about 15 to 20% of the time. That means that 80 to 85% of the time they are going to end up on a drug sooner or later. Here are my alternative therapies for ADHD. This is what I like to try first. Lifestyle changes, diet, vitamins, that includes fish oil supplements with omegas, exercise, and coaching. I think that children should be given the opportunity to improve without drugs, if at all possible. Now, my idea, and of course that sort of is substantiated in the literature about effective behavioral therapy. What is effective? When can you tell whether or not a child's getting better? Well, I like to tell the parents, if 75% of the time their behavior is better, their grades are better, their attitude's better, their ability to focus is better, their impulsivity is better, then their therapy is working. Whatever treatment is being used is working. And what happens is the child's behavior becomes more normal. It creates less stress for you as a social worker, the parents, the siblings, teachers, everyone involved with the child. Remember, we discussed that earlier. ADHD is a family disease. It is a family disorder. It affects the entire family. Unfortunately, it also affects everyone around the child. Now, our goal in treating ADHD is to foster independence in the child so that they learn good behavior skills. They learn how to learn. They develop a learning style. They develop good social skills. And, of course, develop self-esteem as a result of those social skills and all of those other things that they have learned to deal with. We want the child to become a success in life. We want to reduce the child's burden on society, that's taxes, medical care, the legal system. We want those children to grow into productive adults who are capable of forming relationships, maybe getting married and having children, and are capable of independent living, holding down a job. About 10 years ago, I treated a 30-year-old for ADHD who had been misdiagnosed with mild retardation, mental retardation, and truly it was ADHD. And at age 30, he was still living with his parents and was not capable of providing his own self-care. That's terrible. That's a failure of the system. Now, this is what I anticipate happening in the world of ADHD and behavior medicine. We're going to see increasing numbers of children, teens, and adults being diagnosed and treated as ADHD. Unfortunately, as those numbers increase, the number of misdiagnosed teens, adults, and children is going to increase also. Asperger's is going to become the new ADHD diagnosis. More and more kids who look like ADHD are going to be diagnosed as Asperger's and vice versa. More bipolar type 2 disorder is going to be diagnosed as ADHD. We're going to see several new drugs on the horizon in the next 2 years specifically directed at helping control ADHD behavior. And you're going to discover more and more genetic causes for behavior. Already we know of several genetic diseases that result in problems with a child's behavior. There's going to be a severe shortage of qualified counselors and physicians who are competent to treat ADHD and behavior disorders. In the United States, we already have a shortage of psychologists and psychiatrists that are trained in ADHD, and that doesn't appear to be ready to go away anytime soon. Now, that's wrapping up the presentation for you. I'd like to point out you have some new resources. Your biggest new resource is me. Once I've done a presentation, I'm available to answer questions. You can email me at any time if you have a problem, if you would like to discuss a case, if you have something unusual you would like to talk about, please drop me an email. You can find a link directly to me on my website at www.mistakenforadhd.com. And I do answer emails. I tend to average about 500 a day, so please be patient with me. And I hope this has been of some benefit to each of you. Thank you.